Good afternoon. Doctors, the lecture is seen?
Yes. Yes, madam.
Sorry. Yes or not?
Yes,
Doctor.
madam, we can see.
Now, today I'll read you a lecture, hemorrhagic disorders, because I saw a mistake here. Sorry. In the name of hemorrhagic disorders. I am Associate Professor of Pediatrics Department, Rzinkova Natalia Sergeyevna, those who don't know. Normal hemostasis means control and prevention of bleeding from an injured blood vessel. It includes a coordinated interaction between three main elements at the site of vascular injury. These are vessels, platelets, and coagulation factors. The vascular factor. The vessel wall is the first line of defense against blood loss. Local vasoconstriction is induced by neurogenic reflex and is maintained by the vasoconstrictor substances released by platelets. The second one is the platelet hemostatic activity. Platelets play a central role in hemostasis. They stimulate vasoconstriction of the vessel. They turn a primary hemostatic plug to seal small vascular tears. The plug is formed by platelet adhesion. What does it mean? This is sticking of the platelets to the subendothelial structures, followed by aggregation, sticking of the platelets to each other. And they play an essential role in fibrin clotting, in fibrin clot formation. The third factor means coagulation factors and fibrin clot formation. Fibrin clot formation depends on the presence of ionized calcium, blood platelets, and the coagulation factors. Clot formation includes three phases. First phase, this is activation of factor 10 mediated by the intrinsic and extrinsic systems. Phase 2, conversion of prothrombin to active thrombin. And phase 3, this is formation of the fibrin clot from fibrinogen. Here you can see scheme of formation. Fibrin from non-active fibrinogen by the influence of factors. And in this table, you can see names of the factors. Factor 8, antihemophilic globulin. Factor 9, prothrombin or Christmas factor. These are very important factors which take part in pathogenesis of hemophilia. Thromboplastin, Stewart factor, number 10. Calcium, factor 11. Factor of Hegeman, factor 12. And factor 13, this is fibrin stabilizing factor. These factors take part in normal hemostasis, and in pathological hemostasis when present such diseases like hemophilia. Classification of hemorrhagic disorders. These are bleeding disorders like purpura, due to platelet disorders, decreased number. Is called thrombocytopenia. Hereditary thrombocytopenia or congenital aplastic anemia. Acquired thrombocytopenia, which include idiopathic thrombocytopenic purpura and secondary like acquired aplastic anemia, leukemia, hypersplenism. The second one is defective platelet function, like hereditary and acquired. Acquired means after aspirin, after uremia, and such malignancies like leukemia. But in general, you should know that aspirin is contraindicated among children till 12 years old. And if we give such drug, sometimes we can use it only after strict indications due to vital indications. Due to vascular disorders, hereditary hemorrhagic telangiectasia and acquired means nutritional deficiency like scurvy, allergic anaphylactoid purpura, septicemia, and whooping cough. And coagulation disorders may be hereditary like hemophilia and acquired. This is DIC and hemorrhagic disease of newborn. Exist tests for evaluation of hemostatic mechanisms. Tests for vascular and platelet disorders. These are, at first, bleeding time, to assess vascular integrity and platelet adequacy as regards the number and function. Normal value due to either method is 4 to 9 minutes. Blood count including platelet number. Normal platelet number is 150 to 400. Of course, another one what we determine, this is tourniquet test. Is performed by inflating a blood pressure cuff to a point midway between the systolic and diastolic pressures for 5 minutes. Normally, this stress results in fewer than 5 petechiae on an area of skin on the forearm, 2.5 centimeters square. A greater number of petechiae shows us such pathologies like thrombocytopenia, abnormally functioning platelets, or increased fragility of the small blood vessels. In general, tourniquet test will be positive due to hemorrhagic disorders. Bleeding disorders, bleeding. For assessment of coagulation disorders exist another methods. Clotting time, thrombin time, used to assess phase 3. Normal thrombin time is 15 to 20 seconds. Prolonged of thrombin time occurs in fibrinogen deficiency. Prothrombin time used to assess phase 2 of coagulation. Normal prothrombin time 12 to 14 seconds. Prolongation occurs in deficiency of factors 2, 5, 7, 10. Maybe separately defect of each factor, or even combination of all defects. Also, we assess partial thromboplastin time. It is used for assessment of phase 1. Seconds, just 1 minute from Dean's office calling to me. I'm sorry, just a moment. And demonstration disappeared. Disappeared. Just a moment. I'm sorry because they called me from Dean's office. Мгм. Так. Значит, 15 to 20 seconds. Prothrombin time. Used to assess phase 2. Normal prothrombin time 12 to 14 seconds. Значит, это, I said, prolongation is possible of each factor and a combination of them. Partial thromboplastin time is 25 to 40 seconds. And specific assess for individual clotting factors to detect the deficient factor and degree of deficiency. Next table is used for diagnostic of differential diagnostic of bleeding disorders, of vascular and coagulation disorders. Pay attention. This is very important and may be useful for your future profession, because such profession like therapeutist, for example, or general pediatrician, very frequently occur with such pathologies like purpura. But pay attention. In purpura will be positive bleeding defects, coagulation time will not suffer. Will present ecchymosis in bleeding and coagulation disorders possible, but more typical for bleeding disorders. Precipitating factors, spontaneous and coagulation defects occur in minor mechanical trauma. Small trauma may cause precipitating factors. Bleeding time in bleeding disorders will be prolonged, and clotting time, pay attention, will be normal, will not suffer. And all students think that if bleeding, profuse bleeding means suffer clotting. This is a mistake. Coagulation time will be normal in bleeding defects. Coagulation defects prolonged. Щенок Guillain purpura. Etiology is unknown. It's considered as hypersensitivity vasculitis involving the small blood vessels of skin, joints, gut, and kidneys. In most cases, there is a history of preceding upper respiratory tract infection. Hypersensitivity vasculitis may be due virus antigen antibody reaction. As for age, this is mostly between 2 to 8 years, and males more than females. As for clinical manifestation, skin rash in 100% of cases will be recurrent attacks of urticarial or most frequently occur maculopapular rash with charge to petechial and purpuric rash. Distribution mainly on the lower limbs and buttocks. Never on the face, never, remember this. Sometimes erythema multiforme, sometimes angionephrotic edema. Maybe abdominal manifestation in 65% of cases. This is a result of petechial hemorrhages or edema in bowel wall. And severe colicky pain, maybe vomiting, maybe melena in patients, and the general GIT syndrome mimic clinical picture of acute abdominal pain. Sometimes, if we see such rash in patient, not we. Sometimes, if patients have such rash, they apply to the allergologist. They think that this is allergy, but no other complaints besides skin syndrome. Arthralgia, maybe maybe monoarthritis. Involve big joints, ankle, knees, elbows. And clinical picture resemble rheumatoid arthritis. Renal manifestations maybe in 20% of cases. Resemble acute post-streptococcal glomerulonephritis. Some cases may progress to renal failure. CNS manifestations are not common. Occur convulsions, hemiparesis, coma. But with how many years I work, I never seen CNS manifestation among children. The most frequently occur rash syndrome, GIT syndrome, and arthralgia. Sometimes renal. Hinoxian lane purpura. Cutaneous purpura. Acute glomerular inflammation. And deposition of immunoglobulin A. Laboratory findings. Tourniquet test is positive in 25% of patients. Normal platelets and normal bleeding time. Normal clotting. Normal serum complement. Occult blood in stools, ultrasonography on the abdomen for intersuspection, urine analysis, and renal function test to assess the kidney. So in laboratory data, no any changes. This disease we put only due to clinical picture. Prognosis, usually complete recovery. Treatment, symptomatic. Only symptomatic treatment due to syndromes. Analgetics to decrease colic pain, or to give H2 blockers, to give inhibitors, omeprazole, for example. Prednisone in severe cases or in case of CNS manifestation, dose is 1 to 2 milligrams per kilogram per day. Renal failure. May present in some patients. That's why usually is necessary to give steroids. ITP is the commonest thrombocytopenic purpura in childhood, characterized by short lifespan of platelets, normal number of megakaryocytes in the bone marrow, absence of primary disease, normal sizes of spleen, and it may be classified in acute in 90% of cases occur and chronic in 10%. If duration of clinical picture is more than 6 months, we put disease chronic. Etiology. Etiology, this is autoimmune disease. Predisposing factors may be different acute respiratory viral infections like measles, rubella, viruses combined with platelets making, and appear such complexes like antigen antibodies, which lead to autoimmune reaction. Increases destruction of platelets, decreases productive capacity of megakaryocytes, decreases stability of blood vessels. The spleen has 2 roles in the pathogenesis of idiopathic thrombocytopenic purpura. It is a major site for antiplatelet antibody production, It is a major site for destruction of these sensitized platelets. As for clinical manifestation, may be acute ATP, as I said, and chronic. In patient, we can see petechia, ecchymosis, sometimes, but this is seldom, subcutaneous hematoma. And less commonly, bleeding occur from mucous membranes, hematuria, GIT bleeding, gum bleeding, epistaxis. And chronic occur in 10% of cases, as I said, and after 6 months. In laboratory data will be positive tourniquet test, will be very low blood, very low level of thrombocytes, normocytic anemia, bleeding time is prolonged, coagulation time is normal, clot retraction time is prolonged, bone marrow examination shows normal number of megakaryocytes, some of which may show little productive activity. Usually, diagnosis of ITP is clear to the doctor and no need to make lumbar puncture for such disease. Sometimes, of course, maybe atypical lymphadenopathy, and that's why in such cases, in the alone indication to confirm disease or not to confirm this is a puncture. Bone, examination of bone marrow. For some children, no treatment. Patient condition may be satisfactory and may present only skin syndrome. If severe bleeding, we give prednisone or intravenously immunoglobulins. Prednisone impairs the function of receptors on splenic macrophages, while the intravenous immunoglobulins block the function of macrophages in the liver and spleen. Sometimes may present severe headache with neurological signs in any patients with very low level of platelets. In chronic ITP, almost alone method of treatment is splenectomy and prescribe cytotoxic drugs like cyclophosphamide. Sometimes possible to avoid splenectomy if patient constantly receive immunoglobulins. Such children may recover spontaneously. Most patients should be avoid aspirin and sport. In patients with chronic ITP, possible development of chronic bleeding, menorrhagia, mucosal bleeding, and exist 2% of all patients who are resistant to any therapy, to any kinds of therapy. But this one occur rather seldom. Defects of coagulation factors. This is hemophilia A, factor 8 deficiency, hemophilia B, factor 9 deficiency, and hemophilia C, factor 11 deficiency. Hemophilia A, this is hereditary coagulation disorder due to deficiency or functional abnormality of factor 3. It's transmitted as a sex-linked recessive trait. As for clinical picture, it affects male predominantly. Affected females are rare. The patient's mother is a symptomatic carrier, while his brothers, maternal grandfather, maternal uncles are often affected. Positive family history is present in 70% of cases. Occur such cases of hemophilia among women, but in several times less than boys. The clinical manifestations depend upon the degree of deficiency of factor VIII. If factor VIII is less than 1 to 2 of normal, this is severe. 3 to 5, this is moderate. 5 to 8, this is mild. Patients with severe hemophilia suffer from recurrent hemorrhage, and this hemorrhage may occur spontaneously and after small mechanical trauma. During early infancy, may occur after large intramuscular occur hematomas as a result of minor trauma. In childhood, may occur epistaxis, GIT bleeding, hematuria, intraocular hemorrhage, and the most frequently what occur, remember, these are hemarthrosis. And of course, life-threatening emergencies are needed when patient has intracranial hemorrhage and bleeding into the neck. Moderate hemophiliacs usually have trauma after trauma. In laboratory data, will be prolonged. Clotting time, bleeding time, pay attention, is normal. Prolonged partial thromboplastin time, normal prothrombin time, decreased level of factor VIII. What should be avoided? Avoid intramuscular injections, careful dental hygiene, avoid aspirin, surgery avoided. Sorry. So surgery avoided. Prolonged, значит, in laboratory data. Laboratory data, I said, surgery is avoided, dense extraction is avoided. Avoid aspirin. If is needed to make operation, for example, is necessary to make operation. Before operation should be done injection intravenously of factor, replacement therapy. Complications, joint deformation, intracranial hemorrhage, hepatitis, and AIDS. Inhibitors to factor VIII develop in about 10% of all hemophiliacs, leading to a poor clinical response on therapy. Another life-threatening disorder is disseminated intravascular coagulation. This results in consumption of some coagulation factors and platelets, fibrin deposition and secondary fibrinolysis. In pathogenesis, this is endothelial damage of the small blood vessels, release of a substance that stimulates the clotting system, And DIC is the result of such diseases like severe infections like septicemia, extensive tissue damage in burns and major surgery, shock, gastroenteritis, acute liver failure, severe hemolytic reactions, neoplastic disorders like promyelocytic leukemia, adenocarcinoma, and other solid tumors. DIC can be diagnosed clinically by the following criteria. The presence of underlying of primary disease, acute hemorrhagic manifestations, bleeding from injections places, intracranial hemorrhage, melena, hematomesis, ischemia and necrosis, CNS manifestations like disturbed consciousness, convulsions, kidneys, may occur hemolytic anemia due to mechanical destruction of RBC cells. In laboratory findings will be thrombocytopenia, prolonged prothrombin time, partial thromboplastin time, thrombin time, deficiency of factor 1, 2, 5, and 8, fragmented RBC cells, increased concentration of fibrin degradation products. As for treatment, of course, we shall make correction of underlying cause, infusion of fresh frozen plasma, heparin small doses, 100 units every 6 hours, and antifibrinolytic drugs like epsilon aminocapronic acid. Так, hemorrhagic disorders. Have you questions in this pathology or not? Doctors. Have you questions or not? If no questions.
No question, madam.
If no questions, goodbye, and we'll meet you another time.
Sustima, madam.